far the geographic reach is. We often have people staying up very late at night in other parts of the world to tune in,
Oh, really?
which is,
Wow.
yeah, it's exciting. So I'm just going to hop over to Facebook, give everybody a few seconds to join. There we are. We are live. So let's start the show. Hello,
Okay.
everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNETS program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this episode and every episode, and I am a filmmaker and a writer by trade. And I've been working with CCF specifically for over 10 years now. It's 2024. I believe I started working with them in 2012, met them in 2011. So, yeah, the years keep going by, don't they? But in that span of time, we've created, I don't even know how many videos, hundreds of videos, documentary, patient-centric documentaries, live video series like the one you'll watch today, treatment-based videos, conference videos, and many, many more, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, the value of this show specifically, in my opinion, is twofold. One, the information and hopefully answers to your questions that you will get from our guest expert today. And two, the shared stories, shared support, and the community within the show itself, within the overall net community, and even within our show's community. So if you are new to this journey, if you are new to the show, I want to say welcome, and I encourage you to embrace the folks in the comment section. You can see them chiming in and saying where they're signing on from. I encourage you to do the same thing. Reach out, embrace the community. I assure you they will embrace you back. That's one of the most profound things that I love about the net community is how supportive it is. And so I encourage you to lean into that if you are also a part of this journey. Now, before we get started, we want to thank our sponsors, Ipsen Biopharmaceuticals, for their support of Luncheon with the Experts. And we do have this disclaimer from them we always like to say at the top of the program. That is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, you all at home, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF or LACNETs don't necessarily endorse or promote any of the views, opinions, information provided in today's presentation. So, audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, as disclaimers often are, that's a lot of words to say one real thing. We're going to give you good answers to your questions, hopefully, and good general advice, but we don't know your specific case. Each case of this disease is unique. So take that information back home to your home team and make the best plan and path forward for you. Today, I am excited to welcome back to the show after quite a while, Dr. Alexandria Phan. Dr. Phan, how are you?
I am great. I am so glad to be here.
I'm glad to have you. Now, I don't know precisely, but I think it might have been our first year that we were doing this, 2020, in the middle of that fun year of 2020 that we all remember. So, one, I'm happy to have you back after all that time. And two, it says a lot about the show that we're still running strong. So, welcome back. And for those who might have missed your first episode or aren't familiar with your work, tell us a little bit about what you do, where you work, and the role that you fill in this net community I alluded to.
Yes, the taking care of patient with neuroendocrine tumor involve a lot of discipline. My area of focus is I'm a medical oncologist. I'm predominantly take care of patient with neuroendocrine tumors, and I've been doing this for 24 years, essentially in practice with specifically neuroendocrine tumor. So
Wow.
I take care of patient with neuroendocrine tumor, but I also do clinical research and teach about neuroendocrine tumor. So it's a topic I love to talk and can talk probably until the end of the day.
Well, you're in the right place, Dr. Phan. I'm glad to hear that. 24 years in the net space specifically?
Yes.
Wow. So what drew you to that space? What were you focusing on before that? And what was it that, I don't like to use the word attracted, but like that enticed you to want to pursue net specifically?
So when I started this whole thing in about 24 years ago, there was no treatment except a somatostatin analog for neuroendocrine tumor.
Hmm.
And so anything that has very little chance of nobody to advocate for, anything that
Mm.
is difficult, I kind of gravitate to. So that excites me is that I need to solve the problem, understand the disease better, and maybe develop new drugs or get involved and be a part of driving force to make new option for patients. So that was what motivated me to doing this. Plus, I think I see so many patients that didn't have a lot of options. They motivate me to do what I'm doing as well. So yeah, very straightforward. If I have to recall exact moment in time when I got involved in neuroendocrine tumors, when I have to tell a patient, I'm sorry, I don't know that we have any other options
Mm.
left for you. And they're healthy and they still feel well and they can enjoy life. And to say that is very limiting for me. And it it's something I do not accept as a final say.
Yeah, I can understand why that would be hard to accept and be a driving motivator. What's the impact that you seek to have in the teaching realm?
Yeah, so patients. I mean, patient needs within neuroendocrine tumor. Patient needs a physician that is not. It's more than just picking new drugs or just following guidelines. They need people who understand and listens to their story. A lot of time you hear this from your other speakers that it takes about 4 to 6 years to make a correct diagnosis of neuroendocrine tumor. And
Hmm.
so these patient comes to you already frustrated because they have been telling lots of doctor, lots of provider about their symptoms, and they just got diagnosed with this cancer. So the motivation in education is to essentially foster and develop physician or providers that will have the same kind of capacity of patients and taking care of the patient on a personal level, at their level, not just what's the guidelines say, what fits or what's not. It's what they need. So I think that's important to transmit to the new generation of providers for neuroendocrine tumor.
Got it. Thank you so much. Okay, folks, so go ahead and start sending in your questions. Now you know a little bit more about Dr. Phan's expertise, so oncology. I know that we always have a lot of research questions, so that might be good for today as well. Just a little bit of advice and best practices on how to ask those questions. I know I say this every episode, but try to avoid super, case specific, super long questions if you can. There's no maximum on questions, so little smaller generic chunks is easier for us to field in this format at least. And I know sometimes that you have to include certain information for context. So we may ask for that if you're still online. You can, give us a little more information for clarity. But yeah, smaller generic questions is going to be the easiest that we can do. And as I said, if you have follow-up questions, there's no maximum. So start sending those in. And by the way, this is one of the products of our merger with LACNets, which I'm very excited about. We've been working together for months now. Heck, it's August 2024 is moving along. But one of the other most important things that we provide together is the support line, which you can find at lacnets.org/support line. This is for anybody to receive support, patients, caregivers, anybody affected by neuroendocrine tumors. So we'll put that link in the comments, and we'll also try to put anything that Dr. Phan references today, studies, documents, etc., in the comment thread, so you can click the link and easily access those without having to go search for it on your own. So let us know if you have any questions, and we'll get the Q&A portion started. My first question to get us going, Dr. Phan, is thinking about research and thinking about from the outside in. There's clearly been a lot of activity in the net space in the past few years, which is a good thing. What are you excited about that we're currently looking into, that we're currently developing within that bundle, that flurry of activity that we've seen in the past few years? What's got you most excited in terms of being able to help you do your job better?
So yes, no, there's many exciting things to look into, but neuroendocrine tumor as a whole is a very unique kind of cancer. So it's kind of it's out there in the sense that it's not the same model as lung cancer or anything else. So when we talk about research, we have to be very careful in the sense that what's available at research and what's available for new therapy needs to apply to the individual patient. They have to be personalized to what they need, and doesn't mean that it's applied to everybody. So the most exciting things I think in neuroendocrine tumor, of course, is radioactive ligand or radionucleotide therapy. The most exciting in that field is obviously alpha emitting radioligand therapy. It is still in development, but it has the ability to probably be more less toxic and more increase in response rate. So alpha emitting radioligand therapy. Second is within neuroendocrine tumors, we hear a lot about well-differentiated neuroendocrine tumor. What the section that we miss about is poorly differentiated neuroendocrine carcinoma, which has very little therapy. And the most recent, and all of its treatment for poorly differentiated neuroendocrine carcinoma is derived from small cell lung cancer, or it's extrapolated from study from small cell. And so the exciting thing about that is that recently, maybe in the past 3 or 4 months, there's a new therapy. It's called it's DLL3 targeted BiTE therapy, which is essentially a quote unquote immunotherapy targeting your immune system to kill more of the cancer specifically by your immune system, focusing on DLL3 tumors. And almost 80 to 90% of poorly differentiated carcinoma or neuroendocrine carcinoma express this DLL3. It is approved in small cell lung cancer. So I think there will be more study of that type of agent in poorly differentiated neuroendocrine carcinoma. And that is an area that I think is very exciting, especially for patient cancer who rapidly grow very quickly. So to me, those are the two areas that I'm excited about.
Got it. Thank you so much. A few questions already coming in, so I'm going to go ahead and start taking some of them. One from Robin is a very good kind of fundamental net question. Robin says, net tumor found early, but the surveillance plan is 10 years. Why is it so long? Other cancers don't watch that long.
Yeah, though it's absolutely a brilliant question. This is an answer or a question that I go over with every single patient all the time. When I started, the recommendation was 5 years after resection or definitive curative resection. And what we notice in our practice is that recurrence rate can occur. I mean, recurrence of your cancer can occur beyond 5 years. It can occur at 7 years, 8 years, and sometimes even 10 years because it's a slow growing indolent tumor. So if there's a tumor that's left behind or a cancer cell of well differentiated neuroendocrine tumor that's left behind, it takes years for it to come back. So if we monitor it in 5 years, we're going to miss about 50% of the patient who do recur. So that's the reason the recommendation now is 10 years. And many of us wonder if it should be even longer, but I think 10 years is the current recommendation for surveillance after curative resection for well-differentiated neuroendocrine tumor.
Got it. Thank you so much. This is not necessarily a question for you, Dr. Pham, but Doris from Germany says, I'm having trouble finding a doctor. I have carcinoid tumors and I'm not able to get treatment over here. So if anyone, including the internal team, has any links or information for Doris, that would be helpful. Thanks for chiming in, Doris. Hopefully we can get you someone over there. Okay, Dorothy asked, we've been hearing a lot about histotrypsy for several weeks. And, you have too, from the looks of that that response. So Dorothy says, we've talked a lot about in the past several weeks about histotrypsy. Can you just explain what that is, how it's done, and when that might be chosen over other treatments? And you can include any other information you think is appropriate.
Yes, hi. That's a brilliant question. And I may not be able to answer it completely because it's not in my field of expertise. but I can tell you what I know about histotrypsy. Histotrypsy is an external sort of ultrasound, sort of vibrational of the tumors to kill the tumor by that way. If you think about lithotripsy, it's kind of similar to that in the sense that it's kind of shake off the tumor and kill off the tumors. That's the very, very kindergarten way of explaining that. I'm sure it's a much more technology involved in that. I think it's right now the definition of histotrypsy is for liver focused therapy. So a patient who has tumors that has spread to the liver predominantly could be considered for histotrypsy, but there's very specific criteria for histotrypsy. So I would advise you to go to the center that does it and get the recommendation from the provider that does it. And I think one of the things that I notice consistently is they're looking for isolated lesion, smaller lesion, and not huge lesion, similar to any procedure that's focusing for liver-directed therapy. So accessibility to the procedure itself or to the machine is important. But for me, in a general theme, if I'm your navigator in trying to pick out treatment option for you, the people I would send to get histotrypsy for me would be those that had liver predominant disease and not large lesion and not multifocal.
Got it. Hey, thanks, Dorothy, and thanks for your answer, Dr. Phan. That was helpful. Carrie says, with regards to PET scans, is avidity or growth more important in neuroendocrine tumors?
Well, you guys are fantastic question. I forgot how it was to be on the show. I mean, it's a flurry. You guys are almost like physician yourself, very, very knowledgeable. So regarding avidity and size, at the end of the day, it's size that makes a difference. Avidity just tells me on PET scan, tells me the concentration of the tumor. It's the size that allows you to know whether it's increased in size or not. Because our gold standard on assessing response is still anatomical size, not so much as avidity. Right now, there is no data evidence to suggest that the metabolic activities of PET dotatate has any prognostic or predictive of your course of disease. But the only way we can gauge your disease response or progressions or course of your cancer treatment is based on anatomical size. The avidity of disease is useful for me to know if your cancer is now starting to be more concentrated, because it may be an early sign that your cancer is starting to progress. But anatomical size of your tumors on CT scan or MRI is actually more useful to know if it's responding, if it's regressing, if it's progressing or not, because of the current criteria or definition of response. I don't know if that helped. Feel free to ask a follow-up question on that if I didn't answer your question.
Absolutely. Thank you for your question. Next question from our YouTube community. Joseph's mom says 1 centimeter pulmonary nodule, incidental finding on cardiac CT last fall. No growth on 2 follow-up chest CTs, glucose PET negative, pulmonary suspicious for carcinoid net. Is VAT best for tissue diagnosis? And can you establish what VAT is, please?
What is VAT actually?
Yeah, I wasn't sure if this VAT, let's see.
Oh, VAT. Okay, so I'm sorry.
Sorry.
So I have to understand what you
Spelled out the acronym.
VAT. The best way to approach the tumors to get a tissue is really dependent on the location where it is. VAT is more of a local endoscopic. If your tumor is close to the central part of your pulmonary or your chest, usually the VAT is preferred. It's usually done by either bronchoscopist or pulmonologist or thoracic surgeon. I think that is the appropriate recommendation for if it's central. If it's distal, a bronchoscopy is more appropriate. But again, these are some general recommendation because I don't see the scan and I wouldn't know what's the best approach except the procedurist who will be doing it. So the answer is that if it's central, that makes sense, a VAT procedure. If it's distal lesion, then you may have distal meaning peripheral lesion. You may need a bronchoscopy. Again, check with your provider, especially either the bronchoscopist, pulmonologist, or your cardiothoracic surgeon.
Got it. Thank you, Joseph's mom. Nice to see you. I believe this is the first time you have asked a question, so welcome to the show if that's true. A couple of questions about Afinitor, starting with Shane. What is your philosophy on dosage for Afinitor? Start at 10 milligrams and work down if needed, or start at a lower dose and work up?
So Shane, thank you so much for that question. I think a lot of our patients are concerned about Afinitor, but Afinitor is the only drug right now that is approved for essentially pan well-differentiated neuroendocrine tumor. That means lung net, small bowel nets, as well as pancreatic net. So this question is very important, Shane. So to me, for me in my practice, I start with 10 milligram. That's the FDA indicated because it's the only one that's studied in radian 2, 3, and 4. That's the dosage that has been assessed. Now, if there are a patient that is borderline on starting Afinitor, you may want to start at 5. But for me, when you pick a patient or recommend Afinitor, you already take into account their comorbidity or their other medical condition, whether they can tolerate or not. So I start with 10, and then I will see them within the first 2 weeks to see how they tolerate it. And if they tolerate well, I continue at 10 and then dose reduce accordingly to what their side effect profile is. I do not start with 5 because there's no study right now. I mean, the approved regimen is at 10 milligram, not at 5. But if there's a patient that's borderline, for some reason, it is possible. Again, it's at the end of the day, it's personalized to the person sitting in front of you. So, but my rule of thumb is starting at 10.
Got it. Thanks, Shane. And Jean or Jeanne, I always get that mixed up. Please let me know if what's the proper pronunciation. I may have asked that before too. Question is, how long have your PNET and liver metastatic patients remained stable, typically on Afinitor?
So it's variable. I have patients on the average on Afinitor beyond a year. And some actually has been on it for 3 years. But on the average, it's probably anywhere from 9 to 12 months with stability of disease on Afinitor. Now, the caveat here I have to say is that when you start patient on Afinitor, they usually have well-differentiated neuroendocrine tumor. But within that group, you have grade 1, 2, and even sometime 3 sometime. So you can't say that everybody is going to be the same. So comparing respond to a different patient, you have to be very careful because you don't know their diagnosis or their pathology. So for me, on the average in the 24 years, it's about a year. But I have patient that has stable disease beyond 2 or 3 years.
Thank you so much for your question. Next one comes from Samantha. What would the symptoms be with a liver metastasis? My primary is in the body of the pancreas.
So Samantha, that's a great question. Neuroendocrine tumor is a deceiver of many things. Many times they present with no symptoms and the cancer would already spread to the liver. There's no specific symptoms that can be defined, but I will break it down into 2 for you. If I were to talk to you and say what to look for when you need to look for liver metastasis. 1, if you have a functional neuroendocrine tumor of the pancreas, then the expected symptoms of cancer that comes back, especially to the liver, would be those hormonal symptoms that you had initially. Let's just say you have glucagonoma or insulinoma or maybe even diarrhea. They may be the symptoms that comes back. Specifically to the liver would be the other side. That means if there are cancer that comes back in the liver, sometimes doing lab draw can show you that you have your liver function is starting to go up. Your AST, ALT, which is liver enzyme, can go up. On your side, you may not notice anything with those enzymes, but for you to notice something like yellowing of your eyes, enlarging of your liver, abdominal fullness, abdominal pain, especially on the right upper quadrant, those things could be the signs and symptoms of cancer coming back and gone to the liver. But again, once you are resected from your pancreas, you are on a surveillance protocol. Hopefully, between you and your physician and your provider, you will pick up the cancer sooner than you having symptoms.
Got it. Thank you, Samantha. Sotelo says, hello from the Philippines. Hello, welcome, welcome. Now, I know it's very late in the Philippines, so I appreciate you being here. Folks, we are about halfway through today's program. Not quite. If you joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNet's program. Today, our guest is Dr. Alexandria Phan. Great questions so far. Great answers as well. Let's keep it moving on. Have you seen lanreotide begin to work again after a liver debulking surgery?
Liver debulking surgery. Okay, that's okay. So after liver debulking surgery, so I need to step back a little bit to
Sure,
try to
please.
explain this. So for a patient who has metastatic neuroendocrine tumor that has spread to the liver, and you have been on lanreotide, for example, and your disease has been controlled, then after surgery, after liver debulking, and you still have residual disease, lanreotide would make sense to continue you on lanreotide or somatostatin analog for that matter. If it's worked before, meaning able to keep your cancer in control, there's no reason to believe that it won't work after surgery. Now, if before you go to surgery, you have progression of disease on lanreotide, then definitely it would not be the drugs that I would continue you on if you have progression of disease because you have progressed on it. The purpose of lanreotide or octreotide, these are called somatostatin analog, serve two purposes. One is if you have a functional disease, lanreotide or octreotide is there to control your symptoms. But it also serves a purpose of controlling your cancer, meaning keeping the cancer under control. And the chance of it able to keep your cancer under control is pretty good. But the chance of tumor regression, meaning respond to your tumor shrinking or responding with lanreotide, is less than 2%. That means if I treat 100 patients with lanreotide or octreotide, my expectation is about 2 or less of those 100 will have noticeable tumor shrinkage. So in other words, lanreotide or octreotide is really cytostatic more than cytoreductive therapy. So to answer your question, I would say that it's depend on what your response and your benefit achieved before surgical debulking of your liver to know whether it would continue working or not after the surgery.
Got it. Thank you so much for that question. Also, going back to a previous question, Robin says, thanks for the explanation about surveillance of well-defined tumors. Is it the same for non-functional, poorly differentiated ones? Her primary was stage 3 high grade.
For high grade, I consider that a very aggressive tumor. I would monitor them, the same way. But usually, if you're going to see respond for high grade, you're going to, not respond. If you're going to see regression of your tumor, recurrence of your tumors for high grade, you're going to see it sooner than for well-differentiated neuroendocrine tumor. So the protocol may be a little bit abbreviated, meaning you're going to see some recurrence if it's going to happen. If at 5 years for a poorly differentiated neuroendocrine carcinoma and you don't have response, the chance is probably low that you have recurrence after 5 years.
From our friend Ursula, from SA. She says, nuclear specialist has asked for more rounds of lutetium-177 nuclear treatment after my PET scan showed progressive growth. Medical aid now requests FDG PET scan. I am low grade nuclear specialist, says this is unnecessary delay. And also for context, she did have 6 rounds of PRT from 21 to 22 with good results. Unfortunately, now there is growth.
That's a unique question. So, if you have low-grade neuroendocrine tumor, I do not expect you to have uptake on PET FDG or glucose FDG PET. Okay, so I have to go back and say I do not understand why they need a PET FDG. So that is a right rationale for you. Your reasoning makes sense, but I still don't know what their reason that they ask you to do that. So there may be some other suspicious lesion that they can't see on a PET dotatate or PET looking specifically for well-differentiated neuroendocrine tumor. So they may want to see if that uptake on the PET FDG, because the PET FDG will look for aggressive disease. So to go back to your answer to your question, I would say it's dependent on what else is there that they cannot see on the PET, that they will require an FDG PET to be seen. It's a very specific question. So
Yeah. Well, she did say the nuclear specialist said it was an unnecessary delay.
Yeah.
Yeah. Ursula, thanks for your question. Hopefully that helps. Let me know if you have a follow-up question, of course. And good to see you here. Sotolo says, what treatment can you suggest after finished 4 rounds of PRRT for a PNET in the head of the pancreas, 3.8% Ki-67, FYI?
Okay. So if you have, go ahead.
No, I was just going to, you can take it. I was just going to say, obviously, there's many things to consider, I'm sure.
Yeah, I was going to say there are many things to consider because I don't know your response to your PET dotatate, PRRT therapy, and I don't know what's residual and when they restage you. Several things to consider. I think after PRRT, there's a time that we have not totally determined what is optimal time for restaging or respond to be assessed, but I usually say that the maximum response is probably not going to be seen until at least about 2 or 3 months after the last dose of PRRT. So I wouldn't give up hope on saying that this is more or less or respond until you at least 2 or 3 months out from your last dose of PRRT. If you still have residual disease after PRRT, then you have to go back and review options. Let's just say, let's go by a scenario. If you got lanreotide or octreotide, and then you went on to PRRT, and you still have residual disease, your option include, there are many options. Your option include if it's pancreatic neuroendocrine tumor, Afinitor, which is everolimus, now cabozantinib or TKI, or sunitinib. So there are 2 oral therapy, not 2, 3 oral targeted therapy that is available for you. If you have had all of those, then you have to consider either clinical trial or oral chemotherapy. So I need to know, obviously, what else you have received before your PRRT, what kind of response you have before your PRRT to make a recommendation on what is best after PRRT. So many to consider before making a final recommendation in that situation.
Got it. Thank you so much for your question. Hopefully that gave a little bit of clarity, but let me know if you have other questions, please. By the way, Doris, we put the link in there for some information for German carcinoid and neuroendocrine tumor information and specialists, so hopefully that helps. From Glenn, my carcinoid is spreading after being stable. The only course of treatment offered is PRRT. I know the radiation can be hard on other organs. What are your thoughts on this treatment? I have extensive metastatic disease.
So PRRT actually has very little side effect, except one that I think something is worth thinking about. The side effect from PRRT, usually the immediate side effect from PRRT is from the amino acid that is infused to help with the absorption or the elimination of the radioactive ligand. So nausea, vomiting, all of those things, very minimal, nothing like chemotherapy. The long-term side effect or the cumulative side effect of PRRT is actually cytopenia, lowering of your white counts, red cells, and platelet, and that can term sometime can change into prolonged lowering of those count, which we can then predispose you to a condition called myelodysplastic syndrome, which is a precursor of leukemia. Cytopenia is the more common cumulative toxicity from PRRT than the other one that I talked about, which is myelodysplastic syndrome. So I think the side effect of PRRT is not so profound as chemotherapy, but cumulative long-term for side effect is something worth considering in your equation when you think PRRT as an option.
Thank you. Thank you. I've got a question about a lung net. It's more of a statement, but I want to try to give some guidance here. N says 51, diagnosed as ectopic ACTH secreting net in the left lung. Surgeon resected through bronchoscope 3 months back, and they did not keep me on chemotherapy. Told me to follow up after 3 months, I assume. So I just the question is, what is the prognosis of my disease? I know that's obviously hard to say, but what general advice, what things should N be considering or looking for at this point? I suspect that most people, when these things happen, are worried, concerned, you know what I mean, and maybe confused. And so I still want to try to give general advice, even if there's not a specific question or, a hard to answer question, rather.
I think going back to all the questions that you guys have brought up, which I am grateful for the question, the most important thing is that you need to have a multidisciplinary team involved in your care when you have neuroendocrine tumor. That is the most important things. While I can give my opinion for these things, you can see how many other people are involved. That is important in setting that. You always need a navigator, a person that is your captain in filtering these consultant information if you don't have a team. But if you have the team, they work together and they give you a recommendation as a team. So that is the most important thing for all patients that has neuroendocrine tumor is to establish care with an expert that has a team that they work together. Going back to your question about a lung neuroendocrine tumor that has ectopic ACTH and is now status post or after a surgical resection, I'm assuming that there's no other sites of disease and that the only sites of disease is in the lung and that your ACTH production has been shut down because the tumor has been removed. Then from that situation, your management would be surveillance from there on. It is important that you need to make sure you do surveillance both hormonally for your ACTH as well as anatomically to see if your cancer come back. You want to ensure the pathology is typical or atypical so you can understand the prognosis or the natural history of your cancer. In that setting, that multidisciplinary care is very important. You not only need an oncologist that is expert in NET, but you may benefit from a endocrinologist to make sure your ACTH production has been completely gone, because ACTH production can be pretty symptomatic. So hopefully that has resolved for you. To going back to that, to answer your question is that if nothing else appear, you only have that disease, you remove it, your hormones has resolved after you remove it, then the only thing left is just surveillance. And surveillance may start first with a scan about 4 months, 3 to 4 months after your surgery.
Okay, thanks, N. Hopefully that helps. Let me know if you have another question from Jean. I recently had histotripsy, had 9 livers removed. I'm guessing that means tumors. A month later, my carcinoid syndrome is coming back. So is this coming from my bone tumors since the tumors are gone from my liver?
Yeah. So your cancer, when you have a functional neuroendocrine tumors, it is produced predominantly anywhere from the metastatic tissue. Bone typically do not produce a lot of hormone. So if your hormones return, you have to wonder if I don't know. We don't have the answer to this. I hope that you continue on your somatostatin analog, whether you have the histotrypsy or not, because that can keep your symptoms under control. If you stop doing that, and despite the success of histotrypsy, you may have disease that actually is still now producing hormones that is not being blocked by somatostatin analog. So that would be the best answer, not knowing the rest of the history. But to answer your question, yes, as long as you have metastatic disease, hormonal disease, or hormonal symptoms can come back, even with successful histotrypsy, if that answers your question.
Thanks, Gene. Appreciate you being here. From Diane, who's here on behalf of her spouse. My spouse has a WD. I'm not sure what that acronym is. Grade 2, KI 67, 3.9%. Uncinate process, PNET. Well differentiated. That's what that means. See, I'm learning, Dr. Phan.
Yes, yes.
The surgeon is uncertain if he can survive Whipple surgery. Okay, now we're getting to the crux of it.
Yeah.
What other options do we have than Whipple surgery? His SUV on the gallium-68 scan was 118.3.
Yeah, that's a great question, and we're starting to see more and more of two groups of patient that has neuroendocrine tumor. One group is older patient with well-differentiated neuroendocrine tumor, where surgery like surgical debulking or surgery like a Whipple procedure, which is a pretty large surgery, is contraindicated because the survival or toxicity from that is significant. And then the other group, the patient population I see is younger patient who comes in with metastatic, well-differentiated neuroendocrine tumor at age 30s or maybe even younger. So the group that is older that cannot go to surgery, in this case, like your husband, who have an not isolated, but a localized, well-differentiated neuroendocrine tumor of the pancreas, removal of it will require a Whipple procedure, and surgery has deemed that it's probably, while it's feasible and can be done, it is something that may not be able to improve his quality of life or survive from the surgery. So what other option can you do for a localized disease? Sometime a localized disease, if they're well differentiated, can be controlled with cytostatic agents such as somatostatin analog. And so it's being treated as if you have metastatic disease, but mainly trying to keep the cancer under control while preserving your your quality of life and not really taking you to surgery. So you don't have a curative intent, but without surgery, you can't have a curative intent. But you can keep your cancer under control and have some quality of life with somatostatin analog. Other options are there, but it's based on the degree of toxicity that you're willing to go after. Radiation is something that some place will discuss, but there's very little data on radiation for well-differentiated neuroendocrine tumors, such as the pancreas. So I would say one option to consider is a cytostatic agent where the side effect profile is minimum and you can keep your cancer under control while you're preserving your quality of life.
Thank you so much. Also from Diane, is PRRT only for aggressive PNETs?
So right now, PRRT is approved for all neuroendocrine tumor of either GI, pancreas that has a grade 1, 2, or 3. So that is the indication for it. The NETTER-2 have demonstrated its effectiveness for grade 2 and 3 well-differentiated neuroendocrine tumor. In NETTER-1, it's for midgut well-differentiated neuroendocrine tumor, grade 1 and 2. So I think that it is mainly for all well-differentiated neuroendocrine tumor that has receptor positive on a PET dotatate, receptor positive for somatostatin subtype, receptor subtype. So yes, the answer is well differentiated neuroendocrine tumor at the moment.
Got it. Thanks, Diane. Appreciate your questions. From Samantha, LACNets has recently shared. We lost our guest. Just me. So ask me some questions. There she is. I was going to say they were going to have to ask me questions, and I was going to tell them it was going to have to be about filmmaking or social media or something. Welcome back to the show, Dr. Phan.
Thank you.
So Samantha says LACNets has recently shared a post about accepting the supplemental new drug application. The question is, this seems promising and great news. Any thoughts about that? Does that make sense, or do you need more?
I need, yeah, I
Yep.
need a little bit
So,
more.
yep.
Yeah.
So the post I'm looking at it here says Exelixis announces the
Yes.
U.S. Food and Drug accepted the supplemental new drug application for cabozantinib.
Yes. So the
Got it.
Alliance co-op study has demonstrated that cabozantinib actually has activity for well-differentiated neuroendocrine tumor of GI, PANC, and so on. We knew that data since probably 2022 and 2023. So the company that makes cabozantinib is putting in an application to get FDA approval for the drugs. Now, this cabozantinib is currently approved for renal cell carcinoma, hepatocellular carcinoma, and differentiated thyroid carcinoma or thyroid cancer. So yes, I am aware of that, but that is going to make a huge improvement on your options. I mean, we're already using it in our practice or community. Having an approval helps a lot with getting patient access to that drug. The efficacy is very good, and tolerance is something that we're assessing right now in our center. Because I think it's get harder to tolerate the drugs for a long period of time. For neuroendocrine tumor, you typically will require to be on that drug for a long time if you benefit from it. But if you have a lot of toxicity, you're going to have to be off of the drug. So then if we can find a way to help with tolerance on the drug, that would be best. And that's what we're studying at our center at the moment.
Awesome. Thank you, Samantha. Dr. Phan, earlier we talked about, the kind of the flurry of activity we've seen in the net space in the past few years. If you could forecast out into the next 5 years or so, what do you expect to see? What do you hope to see in terms of where we put our attention, our time, our money, our research?
Yeah, so I think first and foremost, what I'd like to see is if we can get our patient advocacy to help us getting approval or recognition by insurers to get PET dotatate approved for staging purposes, not just a one time to see if they can be a candidate for PRRT or not. So an improvement in advocacy will allow for us to be able to utilize what we know already from others' cancer so that we can use in our patient as well. Would be fantastic. But in the future, in the next 3 to 5 years, I think what I'm looking for is clarity on the usage of PRRT. Is that something that can be done, as a pre-op to surgery, post-op to surgery, and how we can optimize usage of PRRT would be ideal. Do we use it in the setting of minimal residual disease? And then the other thing is, how do we monitor a patient that has cancer that has been surgically debulked? How do we monitor them without putting them through a lot of scan? Is there essentially a liquid tumor monitoring pathway that we can monitor them? And maybe 10 years from now, screening for neuroendocrine tumor would be fantastic. So that's 10 years. 3 or
Yeah.
5 years, I'm hoping to understand better, of course, new ways to use PRT in our approach to patient with neuroendocrine tumor.
Got it. Thank you so much, folks. We have just about 10 minutes left in the show. So if you have a question on your mind, now's the time to get it in so we can try to get an answer for you. Next question comes from Karen. I had surgery for carcinoid cancer in the ileum in 2019. There were cells found in the lymph nodes removed. I'm being monitored since. I have had no treatment since. Is it suggested or not since 2 lymph nodes had cells? I was diagnosed with carcinoma in 23, had surgery in 24. I'm receiving no treatments for cancer either. The question is it normal to not have treatment following the diagnosis after surgery?
Yeah, so you have curative resection. It's a very, very common question. This is about a third of my patient who comes is after curative resection. Should I be on adjuvant therapy? Should I be on something to minimize my risk of cancer coming back? Because I have lymph node positive. So your lymph node positive may suggest that you have a higher risk than a patient that does not have lymph node positive after a curative surgery. But there is no data right now that adding any adjuvant therapy will reduce your risk, short of surveilling you to make sure we catch it earlier than later. So the answer is no. There is no data that justify being on adjuvant therapy, whether you have lymph node positive or lymph node negative at the moment. And also remember, your cancer is very much indolent disease. If you follow the surveillance plan, you will be able to pick this up earlier than if you don't follow the surveillance plan.
Got it. Just a few more minutes left. I'm curious, Dr. Phan, with your teaching and working in this space for 24 years, what's the major differences that you see in terms of the new experts and specialists and doctors entering this space in terms of their knowledge and their understanding of this disease versus when you started?
I think one of the things that is most humbling is I find my younger colleague, smarter than me. But the other thing that is actually quite annoying is they're also smarter with social media. And I feel like I'm being left behind on the social
Oh,
media. That's the only two things I notice and a change. My colleagues who are younger are typically, they're very well trained because what we've learned, we pass it on to them. When we first start our journey, we don't know a lot about neuroendocrine tumor. We're the I
right.
wouldn't say I was the trailblazer, but I would say that we're one of those first that try to understand the cancer more. But
Yeah.
through the years, we have those information. We got more. In general, cancer therapy has improved. So my colleagues who are younger are so much smarter with that. But also, they're also smarter with social media. I honestly say I try to avoid it, but I think I come to realize that it's probably not possible to avoid social media.
It's tough these days if you have a message to communicate. And I hear you about them being frustrating. They're smarter, but I guess that's what we want, right? That's ultimately the goal. It's like a parent, right? You want your child to pass you. Some of them do. The good ones do. Well, I mentioned this when you got disconnected for a moment, so I can flip the script if you want. If you have one question on social media, I can field it for you right now. We can switch positions.
Yeah, no, I think sometimes I find it difficult about social media, but I think social media, you're right. When you first started this session today, you said one of value of the show is to
Hmm.
pass informations.
Hmm.
And I think it's the information you're passing out is valuable and it's very helpful. And this kind of social media is important. Posting of social media on a lot of things is also very important. But you have to remember at the end of the day, your relationship with your physician is not on social media, I think. It
Good
has to
point.
be one on one, and you have to develop that therapeutic relationship because your journey on this neuroendocrine tumor is long term. So I don't have any question for you on the social media, but I just want to send out a little pet peeve about your relationship with your net expert or net provider is long term and it's one on one and it's not on the social media.
I think that is super valid, and what you're talking about is depth. right? Like the depth of that relationship versus something surface level. So I think that was excellently handled. We have a few more questions before we go. We got 5 minutes. Let's try to get to them. Another lung net question. Melinda says, I have lung nets and dip neck. I flush every day. Does this mean anything needs to be done or that it's advancing?
No, your lung net and your dip net is the cause of you having flushings and the cause of you having coughing. If you don't have it, that's fine. But I'm just saying the symptoms is probably more on the dip net than lung net. But you I hope that you're on the appropriate therapy to control your symptoms. And sometimes it can be very frustrating because it's not one type of treatment to control your symptoms. But symptoms do not correlate to cancer progression. You have to ensure by images to see if your cancer is progression or not, and not just say, oh, I have more symptoms, therefore the cancer is progressing, therefore we need to change treatment. You need to ultimately assess your cancer with a concrete point with anatomical imaging.
Love that. Thank you. And from Dana, my husband is currently stable with lanreotide injections. Honestly, he's doing very well with this treatment, and every scan shows stability. Great news. His doctor is not really concerned about his condition, which makes us wonder how long can someone stay stable on lanreotide?
So Dana, thank you so much for your question. In fact, that would be a great question for you just to demonstrate my longevity in taking care of patient with neuroendocrine tumor. So I have patient who's on somatostatin analogs probably 20 years ago and continue to be on somatostatin analog with stable disease. That is possible. So the answer is that sometimes patient will be on lanreotide or octreotide for a long time, for the rest of their life, and able to control their disease. So yes, they can be on it for more than 5 years, 10 years. I have patient 20 years.
Got it. Thank you so much for clarifying that. Last question. What do you say to a patient recently diagnosed? They're confused. They've never even heard of this disease. They're scared. What's your first bit of advice to that person who was diagnosed very recently?
I think the first thing they would do is find information and find a NET expert and a NET center to help them. What they need are foundation of support and foundations that will be with them on this journey of neuroendocrine tumor. So it's a rare disease, but they have a whole community here on this conversation, on this webcast that we're seeing. There's so many people on here, and there's so many group out there with neuroendocrine tumor. Then this next thing is find the people that you can use to take care of you or utilize to take care of you. Need to find a NET expert that has a NET multidisciplinary team, essentially a center of excellence. And from there on, you're going to feel so comfortable in understanding your cancer. It's come layers. Knowledge comes in layers. You first layer, you just need to know, am I in the right place? Then you get more information. It's layer up. What's the next step? What's the right step? Then I can then explore and then start getting second opinion, third opinion, however you want. But those things are fundamental. You need to be comfortable first. You need to have a place that you feel your support. You need a captain, a team.
Love that. I love that part about the layers too. That's so well said. And that's exactly what we're trying to do is to help people that, Sotolo, our new friend from the Philippines, says this has been a big help for me, especially since we don't have a net specialist here. Sotolo, I'll also remind you, go to lacnets.org/support line. We can continue to try to give you information. And that's what we have the show for, to add that support and hopefully help those, get the information that they need. And Ruby says, thank you, Dr. Phan, for helping us through this unique disease. I thank you as well. This has been an excellent episode. I appreciate your time, appreciate you being here and sharing your insights and perspective and experience with us.
Thank you. Thank you, everybody, for your question.
Absolutely. Thanks to you all at home. As always, we hope this program helped answer some of your questions. We'll be back in a couple of weeks. And of course, remember the lacnets.org/support line. In the meantime, thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. Couldn't do the show without them. Finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts.